We're supposed to start on time, therefore we'll start early. Is that all right? I have a question to ask this group. The average age of which is about 30 to 40. I'm a PGY 44, and I introduce you here to a PGY 45, I think, Dr. Michael Pinsky, who needs no introduction, therefore I will introduce him. He is a master physiologist with a peculiar habit of being an expert clinician. Often these don't mix, but here they do. He's going to talk to us about mean systemic filling pressure. And before we start, in this younger generation, I want a strong show of hands. Who in this group knows what mean systemic filling pressure is? Not MAP, mean systemic filling pressure. Raise your hand. We need to know. And, a few, yeah, put them up if you know. Great. About half don't, so keep that in mind. And what I propose is I have little to say here because Dr. Pinsky is here. He's going to talk about the theory of mean systemic filling pressure, of which he has deep knowledge because he did a lot of original work going back 45 years. And then if he has 5 minutes at the end, we'll go to practical. And I'm going to show you a reasonable way for about $15, which is what, €12, to build your own device so that you can go to work next week and make a reasonable measure of mean systemic filling pressure. Are we up for it, Dr. Pinsky? Sure. Here's your microphone.
Thank you very much, Paul. Welcome. This year is I graduated from medical school exactly 50 years ago. Yes.
You outranked me.
I outrank most people in this room. Okay, please sit down. Okay. So we're going to be talking about mean systemic pressure, and I want to give it to you in a conceptual way. Let us assume that there's a person, and I'm going to lie them flat, and let us assume that they don't coagulate their blood, and I turn off their heart. Give them maybe something in the brain so they don't have a problem with neuroanesthesia, so they're not going to get a stroke. And I wait about 5 or 10 minutes, and I measure the pressure in the body. And what I will see is that the pressure in the body will all come to a given value. That pressure in you and an eye is about 8 to 10 millimeters of mercury under normal conditions. Okay? You with me? And now I'm going to snap my fingers and turn on the heart. And all the heart is a pump. It's a pump. It takes fluid from one area and pumps it into another under a certain degree of pressure. Okay. For purposes of this illustration, I'm going to assume that the pulmonary circulation isn't there. Okay? So watch. Blood comes into the heart and it gets ejected out of the left ventricle. The amount of fall in right atrial pressure will be really small because the pressure wasn't big to begin with. And the amount of rise in arterial pressure will be pretty high because the vasculature is stiff. And after a couple of more beats, I'll start having a pretty high arterial pressure, and the venous pressure in the right atrium will start to go down. And then I'll be back in my normal circulation. But there will exist one spot in the circulation where the pressure never changed, right? If it's all this way, there has to be one spot that never changed. That's your mean systemic pressure, and it's in the venules of the body. Okay? It is the driving pressure from upstream that makes blood flow back to the right ventricle that determines cardiac output. Nothing other than that determines cardiac output as long as you don't have heart failure. Okay? So that's mean systemic pressure. It's a different way of looking at the circulation. So let's explore the determinants of blood flow from cardiac performance to venous return to the the resistance to venous return as was described by Guyton many years ago. Okay. As you know, if you increase arterial pressure, right atrial pressure, and you look at stroke volume for the left ventricle, cardiac output goes up. That's the Starling curve. And as a matter of fact, Starling measured right atrial pressure when he gave fluids, so that really is a Starling curve. Okay? But if instead of measuring, and by the way, this is your right atrial pressure, this is the patient. So the cardiac output is this, your right atrial pressure is there. Has everyone got that? Okay. So what Guyton did is he took animals and he took all the blood from the superior and inferior vena cava, tied off the azygos vein, and drained it in through a pump to a reservoir and then pumped it out into the pulmonary artery. By definition, it was a right heart bypass preparation. And then on the drainage side of all the fluid, he had a Penrose tube that would collapse down, and he would raise the height of the tube so that when it was above the pressure inside the animal, the tube would collapse down. And he turned up the pump on the other side of the collapsed tube to make sure that at all times that Penrose tube was constantly collapsed down and flapping. So he was having maximal flow at all times. And in that model, he then progressively started with a minus 16 right atrial pressure and progressively increased it, and the flow didn't change in any of the animals. Somewhere around 0, as he started to raise the catheter more, so the pressure went up, he found, to his surprise, that there was a linear decrease in flow proportional to the increase in right atrial pressure. And when he put the pressure high enough, there was no pressure gradient for flow, and the blood flow in the pump stopped. Okay? Based on that data, he realized that an increase in right atrial pressure is the primary determinant of changing venous return to the heart. So, what I've done here is I've drawn a picture that approximates those animals in which as the right atrial pressure goes up, venous return goes down, and when the right atrial pressure and the venous return pressure are the same, the mean systemic pressure, there's no pressure gradient for flow, and the flow is 0. So at the 0 intercept point, that's your mean systemic pressure. The slope of the line is 1 over resistance, but Guyton understood that the venous system really is not a resistance system, it is a conductance system, because it has multiple parallel vessels, just like the small airways in your lungs are not resistance vessels, they're conductance vessels because you have so many of them, okay? And so what causes resistance to venous return to go up is having less parallel channels of blood coming back. And what makes resistance to venous return go down is if you open up more parallel channels coming up. Okay? Has anybody here ever measured venous return? Raise your hand if you've measured venous return. Nobody? Okay. Has anyone here measured cardiac output? Raise your hand. Well, then you've measured venous return. Cardiac output is venous return. They are one and the same. And if you used a PA catheter to measure it, you really did measure pulmonary flow, which is venous return at that very second. Venous return is cardiac output. They are one and the same. Venous return is 100% of what the left ventricle will put out up until the moment the left ventricle dies. Okay? So, let's assume that we have a heart and we have our venous return curve. What ends up happening is that these two, please sit down. I don't know if they're much of a seat, but you have to find a place. These two curves have an intersection that says that to solve the solution for the ventricular pump function, there exists one and only one right atrial pressure and cardiac output that you and your patient can have, and none other. And it's a function of cardiac output, venous return, blood flow distribution. So the cardiac output is ventricular pump function. Venous return is blood volume and blood flow distribution. This point is called the equilibrium point, and everybody lives there. Everybody. The problem is the heart is in the chest. And as you breathe, intrathoracic pressure changes your pressure in the chest independent of mean systemic pressure. So with every breath, you're raising and lowering the left ventricular's function curve. So, what are the determinants of mean systemic pressure and venous return? Well, if the volume out in the periphery is your descending pressure of all the blood volume, remember, no circulation system, remember that? Okay. Then the determinants of static determinants have to be blood volume and vasomotor tone. The dynamic determinants would be blood flow distribution. The more flow that goes to the gut, the higher the resistance, because it has to go through a whole organ before coming back to you. We usually call that organ the liver. Okay? And so there's a higher resistance and a bigger capacitance for blood in the belly. Okay. So let's assume that I have a given venous return curve. And this is important. If I simply hemorrhage the person or they bleed, I will have a lower mean systemic pressure, no change in the resistance to venous return, and for the same right atrial pressure, I'll have a lower cardiac output. And if I give volume, I'll have a higher mean systemic pressure, no change in resistance to venous return. At zero, they all flatten out. And for the same right atrial pressure, I'll have a higher cardiac output. So I can have a cardiac output go up or down with no change in right atrial pressure. Isn't that obvious when I just showed you? And the same is true if you look at what happens with heart failure. Let us assume that line B is a heart that has impaired ventricular pump function. And we define impaired ventricular pump function as a heart that has a decreased stroke volume and stroke work for a given preload and a decrease in the change in stroke volume or stroke work with a change in preload. You have to have both of those to define heart failure. So I would say this is a reduced heart performance. So what normally happens in the real world if your patient has heart failure? They think they're in hypovolemic shock, and they put out pro-BNP and atrial natriuretic factor, and they hold on to fluid. And they build up their central venous pressure and blood volume. And we do that with them by giving a volume infusion. And you call this congestive heart failure. But I call this congestive heart success. This is the only way the body can maintain cardiac output if there's impaired ventricular pump function. Your body never knew that there were doctors, nurses, and medicines. You're in this on your own, baby. And so the body does what it does to stay alive. Okay? So, also, I can change mean systemic pressure by altering vasomotor tone. If I give nitroprusside, my mean systemic pressure falls because I decrease my unstressed volume, and it just swells up. Okay? I increase my unstressed volume. And if I give norepinephrine, I will increase my mean systemic pressure. And thus, for the same right atrial pressure, changes in vasomotor tone will directly change cardiac output. This is why you do not treat hypotension with norepinephrine until you guarantee that the patient is not hypovolemic. Because norepinephrine will increase cardiac output in a hypovolemic patient up to the point that they die. Okay? Yes, you give norepinephrine early, but you're giving them fluids too. Because norepinephrine will always increase cardiac output by decreasing the unstressed volume. Okay? So how do you measure mean systemic pressure? If you want to get around so you can see, there's probably room on the other side. Go ahead. Well, the original way the Guyton did it was a total circulatory arrest. I must admit that that's a hard thing to do. I've done it several times in the laboratory and a few times in the operating room during cardiac surgery, and it's kind of fun, but it's not something you can easily do. Because of that, in 1984, and I've got a funny feeling most of you weren't yet born in 1984, we looked at the instantaneous changes in stroke volume of the right ventricle, which you could easily measure with an echo probe or something like that, to the simultaneous, during positive pressure breathing, increase in right atrial pressure. And we said that that would form an instantaneous venous return curve. Adrian Verspula said, Dr. Pinsky is full of beans. That can't possibly work because you don't have a steady state. What I'm going to do is do an inspiratory plateau at a PEEP of 4, 6, 8, and 10. And wait for the heart rate and cardiac output and right atrial pressure to become equal. And then I'll measure the right atrial pressure, which has gone up, and the cardiac output, which has gone down, and I'll plot a series of those inspiratory hold maneuvers, and I'll look to see what the mean systemic pressure is, because I'll be able to draw a line. Parkin, a brilliant physiologist from Australia, reasoned that if you knew that the complacitance, compliance, and resistance of the arteries and veins were understood, you could calculate a mean systemic pressure analog from just knowing cardiac output, arterial pressure, right atrial pressure, eyes, age, height, and sex. And he used a bunch of normalizations. And this, by the way, is available as an app on your iPhone or Google phone, and it's free. And then finally, we reasoned that although every vascular bed has different capacitances because your muscles, your hands are different, during a steady state period when you're lying there sweet, dumb, and happy, everything is collapsed. The body is behaving as if it's got the same mean systemic pressure. So if I blow up a cuff on the arm and I have an artery and a venous catheter in the arm, when the two pressures come together, that's mean systemic pressure. Okay? And those are and by the way, except for, I revalidated that one, but the others I invented with other people. So that's kind of why I'm giving this presentation. Okay, so I've got the ability now for the very first time, which was not physically possible until the papers were done with inspiratory hold, to measure mean systemic pressure in human beings that are alive with an intact circulation. Okay? This is an example of what I said about positive pressure breathing causing stroke volume to fall as right atrial pressure rises. So this is spontaneous breathing. Don't look at that. Here's the right ventricular stroke volume. This is inspiration. And you can see with the positive pressure breath, CVP goes up slightly and stroke volume goes down. When we applied that and looked at our patients, our pigs, dogs, this was a dog study. These are the points that occurred during a series of positive pressure breaths, and this is what happened with volume loading. And we got a mean systemic pressure measurement there, and the red lines were the stop flow, zero pressure when we fibrillated the heart and opened up an AV fistula. So the gold standard. And it not only worked in that dog, it worked in all the dogs. Okay? Well, Adrian Verspula said, oh, this is a relationship between stop flow, mean systemic pressure, and instantaneous. It works. Adrian Verspula said, I don't like that. And the reason I don't is that Dr. Pinsky is having an unsteady state increase in right atrial pressure, and the body is building its capacitance back up for it. Sort of like if a beaver puts a dam in a stream, the water starts to rise for a while before it falls over, right? It has to build up again. So he said, what I really want to do is inspiratory hold. So what he did is he compared Michael Pinsky's increase in tracheal pressure, causing a decrease in pulmonary flow, to an increase in CVP, to a series of inspiratory holds to decrease to a steady state cardiac output and CVP. And what he found was that there's me, there's him. What he found was when he did that, he got the exact same mean systemic pressure from both techniques in all animals. And that, for me, was a great validation because somebody else wanted to prove me wrong and prove me right. I was very happy. We subsequently became good friends, and Jos Janssen and I are still friends today. Okay? If you look at the effects, Yanita Moss, on her PhD thesis, asked us 15, 20 years later, Dr. Pinsky, is this still true? I can't tell you the number of times people have asked me, that thing that you published 25 years ago, is it still true? Do you ever ask questions like that? The answer is, of course it's true. Physiology is physiology. Unless you've discovered the new physics involved, of course they're true. And I told her the same. She said, do you think we can do it in our patients? And I said, of course you can. So for her master's thesis, she did the inspiratory holds to get the flow, which she measured with a pulse wave Doppler system. I can't remember the name of the system, but it was one that they built themselves with Jos Johnson. And they measured the mean circulatory filling pressure as a series of points. And what she found is that in her post-op surgical patients, she did two things. One, she volume loaded them with 500 mLs and found that the mean systemic pressure rose. And then she did a head-up tilt maneuver and showed that the mean systemic pressure fell. And because these are post-op surgical patients with a lot of fluid on board, the mean systemic pressure was high. Okay? Harkin said, why don't we just assume that the capacitances and the resistance of the circulation are known? And they are. So we will calculate the mean systemic pressure analog is equal to a certain of the right atrial pressure times the arterial pressure times some constants times cardiac output. And this app is called iGuyton, and it was developed by our group in Italy when I was working with Fabio Garacino. It's free. All you have to do is put the data in. It tells you immediately the mean systemic pressure. It also tells you the resistance, the venous turn, a bunch of other things too. Okay? The advantage of this system is it doesn't require that you do anything more than put the numbers in a spontaneously breathing or a positive pressure patient in which you know the cardiac output, arterial pressure, and right atrial pressure. And when we looked at the mean systemic pressure analog relationship to the stop flow, there was a systemic bias. But if you simply multiplied it by 0.3, which is what the algorithm now does, the bias goes away. But probably far more importantly, if you looked at how changes in fluid in human beings changed mean systemic pressure or the analog, the line was very tight with 100% concordance, meaning that if you use it to look at how, if you give fluids or something, mean systemic pressure goes up or down, you can use the algorithm. And the final thing is Maurizio Sassoni used the algorithm. And he looked at a bunch of patients in the recovery room at King's College in London. And he gave 250 mLs of fluid, and he gave 500. And what a surprise, when he gave a bolus of fluid and instantaneously measured mean systemic pressure, it increased. Okay? He then looked at how many patients had an increase in their driving pressure. And he defined the driving pressure as the mean systemic pressure minus the right atrial pressure, CVP. Okay? So the delta venous return is your mean systemic pressure minus the back pressure. And he found that if you were a volume responder, meaning your cardiac output went up, your driving pressure went up. But if you were not a volume responder and you got fluids, your driving pressure did not go up. But in every one of them, the mean systemic pressure went up. So if the mean systemic pressure went up but the driving pressure didn't change, what happened to right atrial pressure in a non-volume responders? What happened? It went up. That is why we have a rule that says if you give fluids to a patient and the CVP rises by more than 2 millimeters of mercury, stop and reassess the patient because it's going into cor pulmonale. Okay? So we did the exact same thing in human beings in septic shock in a recent paper in Critical Care, in which we measured the mean systemic pressure as we gave 30 mLs per kilogram of fluid. And in the hypotensive patients who had given the fluid, we gave them norepinephrine to get the mean arterial pressure to 65. And then if they were still looking sick, we gave them dobutamine. Okay? And there's a lot of information in this paper, but I'm not showing it to you. I'm only showing you the pressure gradient that happens with volume expansion. This is the change in cardiac output. This is the change in the driving pressure for venous return. As you can see, in all of them, as cardiac output went up, the driving pressure increased. When we gave norepinephrine, some patients, the cardiac output went down because of the increased afterload to the left ventricle. And some of them went up, and some of them stayed the same. But all of them followed on that line. And furthermore, when we gave dobutamine, all of them had the cardiac go up, that we had not that many patients. And by the way, this is the exact same line. Okay? So the driving pressure to venous return defines cardiac output. Then we moved on and said, why don't we do something even simpler, which Dr. Mayo will show you later, and let's just blow up a cuff of our patient and compare the stop flow pressure, because that's real easy to do. Now, if you blow up a cuff and only wait 5 seconds, the pressure will fall to about 40 millimeters of mercury, and that's your critical closing pressure of the arterial circuit. Okay, that's not this. You've got to wait 15 seconds for all of it to equilibrate. And that's going to be your mean systemic pressure. And if you happen to have an IV in there and you can measure venous pressure at the same time, they'll both be equal at that point in time. And what we found in this study as well is that the relationship between this arm stop flow and the inspiratory hold was very good. And the changes were equal. And I can measure stop flow mean systemic pressure on anyone with an arterial catheter. Okay? Anyone. And I can measure it as many times as I want without doing anything else to the patient. So, if you know mean systemic pressure, you know the effective circulating blood volume. It'll be determined by the blood volume and cardiac output. So, let me show you something. Here's blood volume, okay? Blood volume here, mean systemic pressure. Let's assume your blood volume is this, and this is your mean systemic pressure. If I were to now alter your blood volume from that point, I would see that as I decrease your blood volume, I would get to some point in which I'd have a 0 mean systemic pressure, but you've still got blood in the body. Now, has anyone here ever butchered a turkey or a chicken or something? Let me tell you, it's kind of gross. You sit there and you chop off their head, okay? Boom, done. Animal's dead. You let it sit there. Squirt, squirt, squirt. Stop squirting. No more blood. Is there no more blood in the animal? No. There's a lot of blood in the animal. So every butcher hangs it by its feet and allows the blood to drain out because chicken meat tastes better if there's no blood with it. Okay? And that's true of all animals. That's because when the stop flow occurs, all that unstressed blood is still sitting in the body. Why is that unstressed volume? It's because if you started at 0 and started filling the body with fluid, you would never distend the veins enough to have them have a back pressure until you got to this point. And then it would go up. Okay? Does that make sense? So you can look at the capacitance, which is the total amount of blood in the body versus the mean systemic pressure, but I don't really care about that. What I care about is the compliance. If I give volume, will mean systemic pressure go up, and by how much? That's what I care about, right? I'm resuscitating out of shock. Okay? So let's do that. Let's give a volume expansion, and the mean systemic pressure goes up. You with me? Congratulations. Now, can you do me a favor? Can you stand up? Okay. You just saw a miracle of physiology. You can sit back down now. Okay. If she had dysautonomia, in the 2 seconds that I had her standing there, she would have fainted and fallen over. Okay? Have any of you ever been on an exam table of a doctor lying flat and they tell you to get up slowly? Because if you get up quick, you get lightheaded. Okay? Why didn't she faint? It's because when she stood up with the increase in pressures, within 2 seconds, she markedly decreased her unstressed volume by venoconstriction. And she did it immediately. And that causes your mean systemic pressure to rise a whole lot. Now let's take this guy, and I'm going to draw a little blood from you because we need to do a sample. And I start to draw the blood from you. You see it coming out in your hand, and you go, oh, and you fall over. Vasovagal syncope. I only took like an ml of blood out, not much. What happened to him? Well, he had vasovagal effect and had loss of sympathetic tone. And what he did was he increased his unstressed volume so much so that he had almost no stress volume. He had no driving pressure for venous return. His blood pressure fell to 0 and he went to the floor. Thank God he fell on the floor. Because if he'd been sitting up, he would have severe cerebral ischemia. We call that the upright faint syndrome. And it's what happens in dentist chairs. Okay? So this is what unstressed volume does. The reality is what your body does to maintain blood flow under hemorrhage, shock, and everything from standing up to lying down is it instantaneously alters your unstressed volume. So when you're in shock, your unstressed volume is really low because your vasomotor tone is really high and you're tachycardic. Okay? That is also why there's absolutely no relationship between the amount of blood in the body and right atrial pressure. Nor should there be. Remember, I told you, for a right atrial pressure, if the blood volume goes up, the cardiac output's higher. For the same right atrial pressure. There is no relationship between CVP and blood volume. Okay? So let's go back to Yanita Mass's study in which she gave 500 mLs of blood to a patient post-op surgery. When she did, she increased the mean systemic pressure from this point here to this point here as the volume went up. How much volume did she lose when she had the patient do an upright tilt to 30 degrees? Well, the mean systemic pressure fell to 15, and this is a straight line, so it means that the sitting up was equal to approximately 200 mLs in that patient. Magic. Isn't that neat? Okay. So years before, using the instantaneous venous return curves that you've seen before, this is the positive pressure, we looked at control and then acute endotoxic shock with volume loading and volume removal. And by knowing initially the blood volume in both conditions, we then measured the mean systemic pressure, the volume going up and volume going down. And we extrapolated it down. These were the two blood volumes. So what happens with acute endotoxemia with the vasodilation is that there is a marked increase in unstressed volume, which makes sense, right? Because you've lost vasomotor tone. The amount that this equaled was approximately 20 mLs per kilogram. And this is in an animal that got the equivalent of acute meningococcal sepsis, the massive amount of endotoxin. You'll notice that the number is not 30 mLs per kilogram. Okay? There is no physiologic basis for the surviving sepsis guidelines to recommend 30 mLs per kilogram for all patients, and I have said that since the original recommendations came out. If you look at the data supporting it, the data shows that at 10 mLs per kilogram of fluid resuscitation until 33, the benefit which is present doesn't change. So they had a chicken soup philosophy of life. If little is good, more is better. So they said, we're going to pick the 30. Okay? How much does your patient in septic shock need? Because they've been septic for a few days, they're obviously not drinking a lot, and they're vasodilated. I do not know. They may need 30, they may need 60, they may need 5. But to give 30 to everyone is a mistake. So what I recommend is you give 10 mLs per kilogram immediately and look at the response. And if they need more, keep giving it. Okay? It's really hard to take it out once it's in the blood. Well, when I was talking about venous return, I lied about something. And by the way, we're doing fine at time. If you have an decrease in resistance, the slope goes up so that for the same driving pressure, the flow goes up, right? If the resistance falls for the same driving pressure, the flow is higher, right? That makes sense? You understand what I said? And the opposite is true if you have decreased resistance. So if I gave an increase in vasomotor tone, let's say norepinephrine, I showed you that the mean systemic pressure increased. Well, what really happens is that the resistance increased. So I didn't get as much of an increase in cardiac output. And if I vasodilate, the resistance goes down. Is this true in real life? Yes. In this study from Jean-Louis Thibault's group, they took patients in septic shock who were on norepinephrine that they were thinking were stable, and they weaned them off norepinephrine. And so they have their on norepinephrine and following a decrease in the norepinephrine dose. As you can see, when you decrease the norepinephrine, the mean systemic pressure went from 32 to 22. Which is exactly what you would expect, right? You've decreased vasomotor tone, right? But if you look at the resistance to venous return, it fell. And so the fall in cardiac output was 0 to slight because the resistance to venous return went down. The same thing happened in a wonderful study that was done by the Dutch in looking at propofol in patients during general surgery. They gave low, middle, and high levels of propofol, and they showed, to nobody's surprise, that if you give more and more central anesthesia that blocks sympathetic tone, you'll see a progressive decrease in mean systemic pressure. But watch. If you look at what happened on the high propofol, they'd vasodilated, and because they had decreased afterload as well, there was an improvement in cardiac function. So CVP went down, but cardiac output remained the same. I wrote the editorial for this thing, and I said, this is a balanced cardiovascular anesthesia. What happens with dobutamine? Well, this is a study in which we did this in patients in which we gave them dobutamine. Why does dobutamine increase cardiac output? The heart can't increase cardiac output. A little bit maybe, but not much. There has to be an increase in venous return. So what we found was that if you focused in on this bottom point and looked at what happened with the venous return, you actually had cut the resistance to venous return by 30%. And what that meant was that even though you improved contractility for the same driving pressure, you had more flow. So what we had is a basic cardiac output and venous return curve, and there's your equilibrium point. You would give dobutamine, you get a little increase in cardiac output, yeah, because you can go so much. But what you really got was with the vasodilation, but the decrease in resistance to venous return, cardiac output went higher. Okay? And you could have yourself measured that. So in conclusion, using non-invasive and minimally invasive techniques, you can measure mean systemic pressure at the bedside. You can derive the driving pressure for venous return and the resistance, and it's changed as you do something like give fluids or norepinephrine or whatever. You can calculate mean systemic pressure analog with real time on your computer. It's called iGuyton. It's free. It works both on Android and Apple, though initially it was only Apple. And if you know the mean systemic pressure, you know the effective circulating blood volume, and you can predict the response to fluid infusion. And with that, I thank you for your attention. And Paul wants to talk to you about a device he's got.
We have a victim here. His last name is Mayo. You want to lie down on this table here? He's a newly qualified intensivist. He's going to be working in the toughest hospital in New York City, Lincoln Hospital. Third busiest ED in the United States. Yeah, this is steady. If you fall down, we'll resuscitate you. He's also fully qualified in echo by National Board of Echo, and he's finishing his TE. And you maintain that we can measure your mean systemic pressure pretty easily. You could go to that iPad thing, but if you want to measure it yourself, let's see how it's done. Want to hold this? And the reason I know this is Dr. Pinsky told me what to do. He told me you can either spend $5,000 or $6,000 buying a rapid occlusion device that's used down in the OR when they want to take a leg off or something without bleeding. But you know, those are hard to get if you don't have much money in New York. So we said, Pinsky said, well, you know, maybe you just squeeze his arm real hard. Try to occlude, yeah, like really, really hard, but his arm's too big. Yeah? So then, yeah, we're talking at a party. He says, it's really easy to do. Just put a blood pressure cuff around his arm, patient's arm. You have an art line in, right? And Dr. Pinsky, how important is it to properly zero that system?
Very important.
And do you think people do that on a regular basis in ICUs in the United States? They actually
do it initially,
do it? Yeah.
But they then forget about it.
Yeah.
More importantly, if you do something like get fluids or something, you want to see it
So how would you, I hate to take a digress, but how do you zero, what is your personal preference? So there are about 6 methods.
Well, I put exactly where you put it, because where it is at the level of the mid-costal line, second intercostal space. That is called the isobed.
Okay. And you have to be very careful to do that because, yeah.
You're not worrying too much with the blood pressure because the reason we zero is because of the hydrostatic pressure of a fluid-filled catheter. And air, though having density, it would make things pressurized. It's not going to have much of an effect changing the pressure if it's up or down like that. But if you're using a fluid-filled catheter, make sure you absolutely zero it right there.
So what I'm doing here is I'm loading a salvage pressure bag here. Yeah. And by the way, Dr. Pinsky, I see a constraint point here. The pressure is low, the pressure is low, pressure is low, and suddenly the pericardial tamponade reaches the pericardial constraint point, and suddenly the pressure in the bag rises abruptly, right? Sorry. So I'm doing some physiology in action.
You see that when you blow in the cuff, nothing happens for a while, even though the cuff is filling up? That's because you're below the unstressed volume. And everything after that, stress volume.
So I'm going to load this. Usually I do it with an auction source. Much easier. My hand's getting a little fire.
Yeah, he's getting
pretty well. And Henry's worried, so I'm taking this up to about 250. And then abruptly I'm going to distribute this pressure into his cuff. And I'm going to have an occlusion of the cuff within about a second, which is fast enough for government work, Dr. Pinsky?
Yes, because you want to do it fast because the first thing that you'll occlude are the veins. And so you'll still have arterial pressure going in.
Did it? 1
Okay.
second.
Very good.
He's now in stop flow in his arm.
Mm-hmm.
You may register, you say about 25 seconds?
Yeah.
What happens if we go to a minute or two?
No, it's not. Then you might have loss of tone in the tissues because if they have no flow for a while, they lose their energy.
10 seconds, watch the arterial line come down, down.
So 15 to 20 seconds is
20.
perfect.
It's a plateau.
Yeah.
That's all you do. That's
Yeah.
the mean systemic pressure.
It's as simple as that. We've done it on many a patient. It doesn't require anything fancy. It's very simple to do, and it works. If you're going to use that, and you're going to use a fluid-filled catheter, please make sure it's zeroed properly right here, and make sure the arm isn't up or down. It has to be the same. As long as it is and everything's stable, it'll always work.
And because I know next week you're all going to build it, the cost items were $6 a piece for these. These were salvaged from some ICU drawer. This is super low cost, super effective. It's approved by the master of this universe. All right. And what is a normal range that we would expect, for example, in the people in this room who haven't drunk too much since lunch?
I would say anywhere from 8 to 12 is a normal mean systemic pressure. But if you're an essential hypertension person, it'll be higher. Okay?
And we often see in the range of 30 or 40.
Surgical patients, absolutely.
Yeah.
But they also then, because it's 30 or 40, they develop edema. Because that's a very high pressure for capillaries.
Yeah.
If they need it in a condition because they're volume overloaded, usually in a day or two, Lasix or dialysis is necessary to get the volume up. Okay?
And Dr. Pinsky, I would like you to summarize. This then brings this group into the universe of Guytonian physiology, which is not that popular or well known, at least among fellows in the United States. So next week, when you're all going to build your own system, how might they use this at the bedside? What would the values be? What utility might they have?
A perfectly healthy, stable patient that you're not worried about, don't waste your time. If you have a patient who you think is in shock and you want to know their blood volume and you want to give them fluid, you can quickly measure this in literally 15 seconds. Turn it off, give them fluid, and wait for the fluid to go in and let it equilibrate. That takes about 5 minutes to equilibrate, and repeat it. This will do 2 things. One, it'll tell you the change in mean systemic pressure for the change in volume, and then wait another half an hour and repeat the exclusion. we would expect that if you gave Ringer's lactate, that the mean systemic pressure would come back to where it was because of the redistribution of the fluid. And if the patient was hypovolemic, what they do, and everyone is hypovolemic, takes in is interstitial and cellular water to maintain blood volume. So when you give them back fluid, most of it extrapolates back out to the tissues because that's where it came from. Okay? Only a little bit will stay in. And you will see that the mean systemic pressure has fallen. Okay? And that's the normal response. If you gave whole blood or plasma, the mean systemic pressure would not change. Okay?
So if there are any questions, I think we're the last in line here. So if anyone wants to finish and take a look at the little device. And I need to finish with an anecdote. The great Antoine Vieille-Baron, master of the RV universe, published a very interesting article where he looked at the mean systemic filling pressure in patients who had died. Their deaths were anticipated. The families had volunteered, et cetera, et cetera. He had an art line and a venous line in, and the last cardiac pulsation, then the patient went flatline at the time of death, and he waited a full minute before measuring the equivalent of a true PMS. And you had a very interesting discussion with him about this, where it was almost an argument. So what error was made in that experimental setup, waiting a minute?
Well, two things. One, the patient was dying, and therefore there was probably a very bad peripheral perfusion to begin with, and therefore the tissues were probably ischemic and acidotic to start. But he waited a minute. If I take smooth muscle of any tissue and give it no oxygen for 1 minute, its tone goes down. The equivalent of me giving nitroprusside to a patient. And I said to Antoine, cher Antoine, he's a friend of mine. We write on right ventricular function all the time. I said, just measure it at 15 to 20 seconds, like we said. And that number will be the mean systemic pressure. You wait to a minute, it's too long. Regrettably, he didn't collect the data on a strip chart to then go back and look at the 15 to 20 seconds. So in that study, he only showed it. And what he showed was a very low number, which is not a surprise at all. Okay?
All right, I think we've timed out, by 15 minutes, but no one fell asleep, right?
Question?
All right, questions.
There is a change in the microcirculation. How about the microcirculation if the change in the...
Microcirculation is upstream from the mean systemic pressure reservoirs. If you have a very high mean systemic pressure, then the microcirculatory pressures go up and you develop edema. Okay? And that's what would happen. But as long as it's not there, the reservoirs are downstream from the microcirculation in the venules, where 4/7 of your entire blood volume lives. Okay? That was a good question. Okay? So I want to thank you all for here, and I hope you have a great time. I've got to adjudicate a whole bunch of posters, and I think they're going to be pouring champagne and stuff in about 20 minutes or so, maybe sooner. So, cheers.